For those of you who saw me talk about Diette, you know that, and those who didn't, I mean, I think that one of the things we're talking about with race disparities, we're really talking about, like, you know, a complex soup of things that coalesce in an unfavorable way. So it isn't just one factor. It's all of these things and more. So education, poverty, occupation, and so forth. There's allergens, there's different pollutants, and so forth. And adherence belongs here also. Something happened, but anyway. But you see it, so the E's there. So adherence matters too. And I want to think about sort of adherence to what and by whom. This is by Clarissa Canino, who's from University of Puerto Rico, Cindy Rand, and Elizabeth McQuaid. And it's very complicated. And if you're at the back, don't worry about squinting and seeing the actual details. I think the point is that, you know, if you're going to try to develop a framework of what causes healthcare disparities for a given illness, it isn't just one factor. It's all of these things. And it includes healthcare system issues, provider and clinician factors that we heard a lot about, individuals and family, social and environmental context. So I'm going to hit on a few of these things as we talk here. What I want to emphasize is this. I think that, you know, often when we're talking about adherence, we're assuming that we're talking about a patient. I think that's part of it. Sometimes we're talking about healthcare providers, and that's part of it. There's more to it too, which I hope you'll see by the time I'm done, about adhering to what and by whom. A good starting point sometimes is the guidelines, the to what. You know, so can we adhere to the guidelines, and who ends up doing that? This just refers to the most recent iteration of the National Heart, Lung, and Blood Institute's guidelines, which came out in 2007. And, you know, some of the things that we know are true are that there are disparities in terms of how well those guidelines are adhered to. This doesn't say why. This looks at, for example, this is a study that was done across the country by a group that I work with, 6,600 patients, all of whom were in managed care. And one of the things you can see is that blue represents white patients, the red represents black patients, using an inhaled corticosteroid daily, having a peak flow meter, having an action plan, knowing how to adjust medications for flares, that there's a discrepancy there based on race, and that's after adjusting for other sociodemographic factors. So maybe the most important one being, you know, using the inhaled corticosteroid daily, not ideal in either group, but clearly an important difference. So, you know, when we look at what Institute of Medicine has to say about healthcare disparities, there's a great book. I know everybody here has looked at it and been through it, Unequal Treatment. They talk about the fact that there's many sources of disparities. And I think this is true, that everybody who sort of looks at this, every organization, every group that looks at this, sees that there's all different levels to where the disparities come from. And one of the ones I want to focus on there, that third one, which is patients, what they said, there's a small impact of refusal. I think this comes up over and over again, which is that it's not really the patients. If you measure something about patients, there's a little bit there, but it isn't mostly the patients, it's mostly other things. And I'll focus a little bit on healthcare providers too, and some of the issues with them. There's a study that was done, actually a fairly large study, very recently published in American Journal of Respiratory and Critical Care Medicine, looking at race differences in factors associated with adherence to inhaled corticosteroids. And they studied internal and external factors. Internal factors for them were things like knowledge. External was things like socioeconomic status. So internal and external. And they found that for blacks, for example, readiness to take inhaled corticosteroids was the only internal or external factor that they found associated with it. And that only explained 5.6% of the variance, meaning that didn't explain very much. Most of the reason for non-adherence was captured by something that they didn't measure. It wasn't mostly a patient's own makeup, if you will. And I think this has been pretty much true throughout, which is that particularly race-based disparities, there's very little signal coming from people themselves. There is a signal that can come from here too. This comes from Institute of Medicine, and it talks about communication. Arlene mentioned communication being central, and they talk about the healthcare decision making that has to happen. What I've circled in the upper left on the figure is the place where the doctor or the nurse and the patient are sitting next to each other. It looks to me like the guy's wearing dark glasses too. I'm not surprised that he's not getting everything he needs. I don't know. I don't understand the picture, but you get the point. Something has to happen here at that particular encounter, that there has to be an exchange of information. You can't take care of asthma if you can't collect data about how sick somebody is from an asthma standpoint. And what the guidelines say is we need to do this, and we need to do it every so often maybe being 1 to 6 months with an ongoing monitoring of the asthma. This comes from a study that we did, also a national study, and this was more than 3,000 paired patients and their doctors. And the patients were graded at the time as mild, moderate, or severe based on how they reported their frequency of symptoms, nighttime awakenings, beta agonist use, and so forth. And what you can see is about half the patients in the study would be graded as severe, most of the rest as moderate. Their own doctors were asked to just check a box, are they mild, moderate, or severe, using the criteria, and the doctors tended to say they were mild and moderate. So there's sort of a disconnect between what the patients were able to report and what their doctors said about themselves. And one of the things we saw is that there's a consequence to this. So what this slide shows is This is just the particular stratum of patients who were moderate, all of whom would qualify to be on a long-term control or inhaled corticosteroid, perhaps. And all of them would be eligible for every kind of asthma care that you could wish for. The goal here would be 100% in all bars. But what you see is all these patients themselves graded as moderate, but the doctor rating green, yellow, red being mild, moderate, and severe. And the milder a doctor graded them, the less likely they were to have any indicator of care. So clearly there's a consequence to the doc getting the information that's proper and correct in the encounter. Sandy Okello, who's one of our colleagues in pediatric pulmonary at Hopkins, did this analysis, and he showed that underestimation was not only a phenomenon in general, but it was differential, and so that there was a greater proportion of black patients whose doctors underestimated what their severity was than did white patients. And so that it's a potential for that to be a partial explanation for healthcare disparities. There's other things too. You know, when you look at those figures about the different components of the system that have to be there, you know, it says that, you know, we've got to assess our patients every 1 to 6 months. Well, we know that there are system factors like this. If the usual source of primary care is less likely if they're black or Hispanic than white, so having that potential for the contact is racially determined in part. Among children on Medicaid, more ED visits and fewer primary care visits. So depending upon the insurance type, that there's a shift in the type of encounter that occurs as well. So that's this framework here. We're talking about some of these factors, provider and clinician factors, some of the operation of the healthcare system. I want to switch gears and talk about a couple other things too. After just reassuring you with this, which is that it looks like for the most part that there are ways to actually move things forward. That most of them are multifaceted interventions. They tend to tackle multiple aspects of the system at once. And Tyra Bryant-Stevens, who's at the University of Pennsylvania, did a great summary of this, showing that if you do a multifaceted intervention where you try to target various aspects of the provider and the patient, that you can get better adherence to the guidelines, less symptoms, and so forth. So we think about another aspect of adherence, which isn't medication-based, but you think about what the guidelines say about occupation. This is an important issue. So the guidelines say to me as a clinician that I should ask patients who are employed and have asthma about possible occupational exposures. I can do that. It doesn't solve the problem necessarily. I mean, I can ask people to try to be away from, you know, a certain workplace, but for the most part, you know, the job is somebody's livelihood. The occupation is important. It's not a simple matter of me just saying, where do you work and do you have an exposure that matters? And one of the things I'll show you here, if we're trying to understand disparities, what I show here is employed persons 2009. So this comes from the Bureau of Labor and Statistics from the U.S. government, what the proportion of the workforce is. And what you can see is that 14% of the workforce is Hispanic, 11% black. What I've also taken is from a document called Up to Date, which is a good source of, you know, quick medical information. It's a table of major causes of occupational asthma. Don't read them. There's a whole long list of them. There's both the components and then where people work. But one of the things you can see is textile workers is one, but that workforce is 36% Hispanic and 21% black. So it's not simple enough for me to just say to my patient, you know, are you a textile worker? I mean, it's because I can't necessarily change the occupation. Another example, painters, 40% Hispanic. So there's a differential distribution of where we work depending upon who we are and whether we're in an occupation at risk. And so when I say adhere to what, I think part of what we have to adhere to is different standards. And so this is an example from the United States Department of Labor, nearly 1,000 seek solutions at National Action Summit for Latino Worker Health and Safety. I think part of the adherence issue isn't just adhering to what's already there, but also sort of shifting what it is that we want people to adhere to. We need different work standards, for example, and different work standards for different groups. Irritants, same idea. Expert panel recommends that clinicians query patients who have asthma about exposure to irritants that may cause their asthma to worsen and advise them about reducing them. Well, I can do that. And to a certain extent, I can be successful, a certain extent not. There's an example here with schools, right? So where does the child go to school, for example, and could it contribute to their healthcare disparity? If you look at this from Rob McConnell and a group in Southern California, there's really good data now that show that the outdoor traffic-related pollution is a likely cause of new onset asthma in kids, and it depends upon where it comes from. So this shows ambient pollution, which means just in the air shed overhead. Home, they measured also, and then school. And each one of those was independently associated with risk of asthma. So meaning it wasn't just living in Southern California, not just having it at your home, but also where you went to school, also a risk. And those are specific pollutants that were traffic related that linked to a child having asthma. Well, how does that explain the disparities? Well, this is a different study from a different group This is also looking at California. But as you go from left to right, this is looking at the number of vehicles, from the least number of vehicles to the most number of vehicles going by the school in a given time period. So that all the way to the right is more vehicles going by. And what I've helped you with the red arrow is showing that if you're black, you're more likely to attend a school that has lots of traffic. If you're Hispanic, more likely to attend a school with lots of traffic. If you're white, less likely. So in terms of race-based asthma disparities, there's a story to be told about where the school is sited. And so when you say, adherence, adhere to what? Well, you need to think about what the standards are for where a school should be placed and how the air should be handled in the school when it's near a highway, for example. Other issues too, right? We don't live randomly, and depending upon who you are, helps to determine what pollutants come into your neighborhood. And this shows from their EPA standards that Hispanics and African Americans are more likely to live in a neighborhood that would fail an outdoor EPA standard. So why does that matter? Well, I'll show you a couple reasons. One is, when thinking about adhering to what, this is a map of the United States. Two things to note on it. One is, so this is a satellite map, and it shows what the particulate matter concentration is on average in different regions, right? So we're here. Red is bad, right? So that's 18 of these units, micrograms per meter cubed. 0 is much better, which is Pacific Northwest. And you can see there's a couple areas of the country which have more particulate matter. And this matters because we know that it can induce asthma, we know that it can worsen asthma, and so where in the country we live matters quite a bit. Just give you an example here of something else. This is the same idea, but this is a world map, and it's a different scale, where the other one went up to 18, where the worst on the scale in our country was 18 of these units. This is 80 of these units, and one of the things you can see is the US actually fares pretty well. The red areas are actually yellow compared to the rest of the world. If you look at Northern Africa and parts of the developing world, India and China, there's a lot of red there. And this isn't an accident of geography. It's not just happening because of bad luck. It happens because of policies. And when you think about what it is you want to adhere to, this is a patient of mine sent me this picture who's a nurse who works in DC, and she was doing perfectly well before she went to China. She developed an asthma flare as soon as she got there, and she was on prednisone for a couple of weeks. And this was a day when they hadn't shut down the factories for the Olympics. This is what it looks like on a typical day there. And what you can see is when you don't have a policy to adhere to, for your industrial sources to have limits, this is what happens in parts of the world where we don't have good laws to adhere to. Why does this matter? Well, this is from the American Lung Association website. This says clean air at the crossroads. Polluters and their politicians want to take away protections from toxic air pollution that you have under the Clean Air Act. It's the Clean Air Act that's responsible for us having yellow and green on that map and not red. So in terms of the standards, we need to protect the ones that exist. We need to strengthen the ones that are not strong enough. One last point about this. So what's it got to do with health disparities? Well, this is one final example, and I'll show you. I've got 1 minute for this, right? Good. So this is a neat map because this shows where we are, right? So this is Maryland and DC area. Those 5 red dots are existing power plants, and they're power plants that generate energy that we need. And these are pollution monitors. These little dots are just where the pollution monitors go. And this is a thought experiment. It was published a couple years ago in Environmental Health Perspectives, and the question was, what if known existing controls were added to the smokestacks of these power plants? What would happen to asthma downstream? Because the air doesn't just distribute out widely like this. It actually flows along known patterns. So one of the things that's known is that if you reduced particles, for example, coming from those power plants, that there'd be some distribution, and the biggest impact would be close by where it's dark, less impact as you get farther away, but it's also not a perfect series of circles because of where mountains are and winds and so forth. And what they found is, this is a map of the district, right? So this is District of Columbia. And one of the things they're able to estimate is because of where people live and who they are in that city, that African American children making up 21% of the population could account for a 64% of a theoretical drop in asthma ED visits because of where the air flows and where the pollutants would track, that you could have a differential impact by race. So this is a conference about disparities. That's why I show this. It's not just a theoretical notion for what you do for the whole U.S., but actually where it flows in terms of the people who inhale it matters as well. So this shows American Lung Association doctors from leading health organizations urge Representative Barton to review the facts on air pollution. This is one of our jobs as healthcare interested people to also, I think, engage our elected officials and educate them on this stuff. Help move the standards also for which people need to adhere. So I'll skip that. So my conclusions are a few things. One is we know respiratory diseases have complex origins, also necessarily complex solutions, right? It isn't ever just one single issue. Adherence to something, I think, plays a partial role. It's not the whole thing. Systematic solutions are needed to reduce the role of adherence on disparities, and that's been shown that things that are more comprehensive work better. But the adherence to what and by whom is something I think those of us in this room can also help to think about. It's not just a matter of saying this guideline exists already and I need people to do what it says. It's also a matter of helping to sort of craft what the message is of the guidelines, whether they're healthcare guidelines or pollution guidelines or other things, so that the people that have to adhere to those things have the best standards as well. And that's it.